So firstly, I don't work for Health Innovation Manchester. I work for Manchester NHS Foundation Trust. My main role is an innovation and IP lead at the trust. So my day job is to help clinicians develop early stage ideas. And this is slightly different because this was an existing CE marked product. It wasn't an early stage idea that we were trying to move forwards. My background is medical device engineering, and I was asked to be the project manager for this project as part of the ADA programme. So I think I have, or at the start of the project, I had the same perception on all of this as Joe Public would have. So I'm going to go through that initial perception and potentially some of the misconceptions, because this starts, and I appreciate I may be teaching you quite a lot of you to suck eggs, but this starts at a very early stage and explains the problems at quite a low level. So if you experience chest pain, obviously you might be thinking you're having a heart attack, and the natural thing to do is to call an ambulance. And ambulance turns up, and my understanding was a paramedic would be able to say, yes, you're definitely having a heart attack, you're definitely not having a heart attack. And you would then be taken to your local A&E department. And then there would be further tests undertaken to determine exactly what sort of heart attack you're having or exactly what sort of treatment you need. And you'd then be sent down the road to, or in the same hospital, to the heart attack treatment centre where you'd be treated for your heart attack. So that was my understanding at the very start of the project. Now, the misconceptions in there, first of all, not all chest pain means you're having a heart attack. In fact, typically only about 5% of people who dial 999 with chest pain are actually having a heart attack. So it can be a symptom of indigestion, stress, lung problems, or musculoskeletal issues as well. The second misconception is all ambulances and paramedics are the same, and that's not the case either. You can get different vehicles with different levels of equipment on, and obviously the paramedics have different expertise and ability to undertake different tests. You would think that an ECG provides a definite diagnosis of a heart attack. That's not the case either. It only provides a definite diagnosis for a particular type of heart attack called an ST-elevated myocardial infarction, or a STEMI. Not all A&E departments are the same. They're split into different types. There's type 1, 2 and 3. There's something called an SDEC, and there are also walk-in centres. And most hospitals don't treat patients for heart attacks. You have to be taken to a regional heart attack centre to have the specialist treatment. So the only way that you can definitely diagnose myocardial infarction is with a troponin test. And that is currently undertaken in A&E departments using lab-grade analyzers. So the issues with that pathway, well, for the STEMI patients, so these people who definitely are having a heart attack that can be diagnosed with an ECG, that pathway is pretty good. They tend to be taken straight to the regional heart attack centre from the scene by the paramedic. But for all of these other groups, so the NSTEMI, so these are people where the ECG is suggesting they might be having a heart attack, but it's not a definitive diagnosis. And also all the people who have got indigestion or anxiety or chest pain, they tend to get taken to their local A&E department where you have further tests and workup to see exactly what's happening. So for this NSTEMI group, the people who are having a heart attack, but where it can't be accurately diagnosed at the scene, they would typically be taken to the A&E department. They'd have a troponin test in the A&E department. That would confirm that they're having a heart attack, and then they would get back in the ambulance and go to a regional heart attack centre. And for the other group, they might go through the same set of tests, or they might go through other tests, and the clinician might diagnose a different condition. They might go somewhere else in the hospital, or they might be told to go home and say, well, you're not having a heart attack, you've got indigestion. Or they might be asked to go to their GP or something like that. So So there are now point-of-care testing devices available, which enable troponin tests to be undertaken at the scene by the paramedic. And the potential use of that, well, for the STEMI patients, the test result would just provide further confirmation to the paramedic that the patient is definitely having a heart attack. For the NSTEMI patients, they would also get that confirmation. So they could also be taken directly to the heart attack centre. And then for all the other patients, it would confirm that they're not having a heart attack. It wouldn't say what else is wrong with them, but it means that potentially they could be taken to the right place straight away, or even left at the scene. So again, the potential benefits of that, the patients who are definitely having a heart attack, they go immediately to the heart attack centre and get the treatment they need. Hopefully there would be a reduction in secondary transfers between the A&E department and the heart attack centres. And there'd also be a reduction in the people clogging up A&E who are having suspected heart attacks. That if you can provide additional information when they arrive at A&E, there's potentially a quicker triage or transit through the A&E department. And you would hope that there'd be a big group of patients where the paramedic could say for certainty they're not having a heart attack. You know, you've got indigestion, you're having a panic attack, something like that, and just leave them at the scene, which would save the whole need to take them to A&E in an ambulance. Now, there's another thing you need to be aware of called Tmax. Now, this is an algorithm that helps clinicians determine if a patient is definitely having a heart attack. So it takes 7 clinical indications and you feed them into the algorithm and it gives you a risk score. So you could be very low risk, moderate risk, or high risk. Now, this algorithm is currently only used in A&E departments and hospitals because you need the troponin test result to feed into that algorithm. But by potentially getting the troponin test result at the scene, you can use the algorithm at the scene, which provides further diagnostic ability for a heart attack. So when Health Innovation Manchester were awarded this big pot of money to run the Advanced Diagnostics Accelerator, one of the projects was to implement and evaluate the use of point-of-care troponin testing by paramedics at the scene. And that was going to be a joint project between MFT and NWAS. Now, usually when you apply for grant funding, part of the process is to do a really detailed plan of your project, and your grant is assessed on that detailed plan. Now, for various reasons, for this particular pot of cash, a number of projects were proposed, but they weren't planned out in detail before the grant was awarded. So the first job that we had to do, that myself and Rick Bodie, who's going to speak a bit later, had to do, was to try and work out what we were going to do over that 2-year project. So that was our initial plan. We had an initial 6-month setup phase, and then another 6-month baseline data collection phase where we were going to collect data from NWAS, we were going to collect data from A&E departments and try and understand what's happening currently. And then the hope was to use the point-of-care test device and the Tmax algorithm to actually change care pathways, to initially rule in people who are definitely having a heart attack at the scene, and for all of those to go direct to a heart attack centre. And then in the fourth phase, to rule out heart attack at the scene. So either those patients would be taken to the appropriate A&E department, or potentially they'd just be left at the scene. And there was also a phase to develop an electronic version of Tmax, which could be used by the paramedics on the scene. Now, when we had our first meeting with NWAS and presented that potential project, we didn't get an overly enthusiastic response. They thought it was too ambitious, and they were very reluctant to make any changes to the actual care pathways until the device had been fully evaluated in service. And some of their concerns are on this slide. So first of all, are paramedics able to use a device? How does it affect the time on the scene? How will that test result and the Tmax score be handed over to A&E clinicians? What did paramedics think of the device? Would they be happy to use it? Would they trust the results, etc., etc.? So we took those on board, and this is what we actually did. It took us a year to set the project up. So that was getting a project plan agreed, getting NWAS approval, implementing subcontracts with NWAS, engaging with the Greater Manchester Cardiac Network, getting all this baseline data. So the first 50% of the project, or the original 2-year project, was setting the project up. In year 2, NWAS started patient testing. There was a process of interviewing patients, interviewing paramedics, and we started the development of the electronic version of TMAX. And then the project was extended. So patient testing was carried on for another 9 months. We did a load of work on data analysis, health economics analysis. We're going through the process of approving the electronic version TMAX, and then we're writing up and disseminating the results, which is part of this workshop today. No changes to care pathways were made, so patients carried on treating as per current care pathway. So for this particular project, we used a Siemens point-of-care troponin test device. There are other devices available, such as the Abbott and Quidel Ortho. The project findings are generally applicable to all of these devices, but there'll be some variations. So, for example, Siemens uses capillary blood and has an 8-minute test time, whereas the Abbott device requires venous blood and has a 12-minute test time.